everybody. Assalamu alaikum. I'm Dr. Tasaduq and I'm a consultant nephrologist and renal transplant physician in Dow International Medical College. And today our topic of discussion would be acute renal failure. So as you all must be knowing that there are two types of failure, like acute kidney failure or chronic kidney failure. So today we are going to discuss about acute kidney failure, renal failure. What are the objectives of our lecture today? Number one, the definition of the ARF, acute renal failure. What is the epidemiology? How much cases we are seeing? I mean, the percentage of acute renal failure in our society of different categories. What is the etiology of ARF? How it occurs, what is the mechanism? That means, is it pre-renal, is it renal, or it is post-renal? So it is important to know the etiology of ARF that can help us managing acute renal failure. Last is the management of ARF. How we are going to diagnose, because it is very important for a physician to diagnose it before he starts treatment. So the definition of the ARF is deterioration of renal function over a period of hours to days, resulting in the failure of the kidney to excrete nitrogenous waste products, right? And to maintain fluid and electrolyte homeostasis. Acute renal failure, rapid deterioration of renal failure. How can we say this is acute or chronic? Because we don't know when a patient comes to us if he has a deterioration in the renal function, like creatinine is a blood marker which we usually see. So we cannot differentiate, is it acute or chronic? So number one is the history, which we take it from the patient, and other in which the patient will tell that he was perfectly fine, till last week, he has no renal issues, and suddenly he is anuric. So we would be knowing that this is an acute renal failure. So what we call ARF, rapid deterioration of renal function, that is increase of creatinine 0.5 milligram per deciliter in less than 72 hours. Okay, this is very important concept of understanding that your normal creatinine is less than 1.1 or 1.2. If your creatinine creeps up to from 0.9 to 1.5, that means you are in ARF. You are having some renal issues. So it is very important to address early. And secondly, it is the accumulation of nitrogenous waste products which are excreted by the kidney. If your kidney is not functioning, then there is accumulation and there would be elevated blood urea nitrogen and creatinine level. And lastly, which we can see without any laboratory help, is the urine output, which is very important to know, because we being a nephrologist, urine output is the most important thing for us. And we usually ask how much urine the patient has poured in the last 1 hour, 2 hour, or 6 hour, or 24 hour. This is very important. And you must be aware that what is oliguria? Oliguria is decrease in urine output, less than 400 ml urine output in 24 hours. And anuria is less than 100 ml urine output in 24 hours. What is the epidemiology of this ARF? It occurs in 5 to 7 of all hospitalized patients. It has a very high morbidity and mortality, because mortality actually is high, not the morbidity. I'm sorry, the mortality is high because if a patient comes in a critical care area with a sepsis, so their percentage of mortality is very high, because these patients usually come up with multi-organ failure, and which includes kidneys as well. So it is important that we should avoid acute renal failure, we should identify and we should manage properly, because the mortality is pretty high. If you compare it with without sepsis, it's 30 to 45%. What are the top 5 causes of AKI in Pakistan? Number one, as we all know, diarrhea is very much common. Maybe not in the cities, but in our most of the village areas or non-commuted areas where the impurity of water is there and they don't have the clean water. So there is many chances of having diarrheal diseases. So this is the number one cause of AKI. Number two is the sepsis, which includes pregnancy-related septicemia as well, because there are so many females which comes to us during pregnancy in AKI, because there are multiple causes. They have sudden postpartum hemorrhage, they have severe hemorrhage, which would lead to hypovolemia and which would lead to AKI. So sepsis is number two, and number three is acute malaria. Malaria is also very common, but now we are just after the coronavirus, so we are not thinking of malaria anymore. But we should always remember that we are a malaria epidemic area, and we have epidemics of malaria as well. So we should always remember that. Drug-induced and hospital-acquired. Lastly, just talking in the current situation, the COVID-19 virus, the coronavirus, it also causes acute kidney failure. Somehow, it has a mechanism that most of the patient who comes to us in an intensive care unit ends up in renal failure as well, because this virus has a tendency to cause pre-renal AKI. So this is I want to show you that this is a graph which is showing that how much length of hospital stay would increase if the renal involvement is there. Whenever there is a AKI or multi-system organ failure, the number of days is less with cardiac, neurologic, hematological or respiratory. But if they are with ARF, the length of the hospital stay would increase. So it would take some time to get better. What is the etiology of ARF? It is very important to understand it is pre-renal, renal or post-renal. This is the structure of your kidneys, how the kidneys are, they are connected, and with the ureter and then the bladder. So we should always be knowing the anatomy so that we have a vision that where is the problem. So if you see in this picture, this is A is a pre-renal, B is a post-renal, C is a intrarenal. You are seeing this A means there is pre-renal obstruction. B is post-renal obstruction. That could be just after the kidney, just before the, going into the bladder, or bladder outlet obstruction. That all lead to post-renal. And there are certain diseases which will cause intrarenal obstruction. What is the cause of acute renal failure? What are the causes? This you should always be remembering, that acute renal failure is all divided into pre-renal and post-renal. And there is an intrinsic renal causes. Pre-renal we will discuss later, and post-renal we'll discuss later. There are intrinsic renal causes. Now we are talking about renal. So renal is divided, if you remember the anatomy of the kidney, there is a glomerular, there is a tubular, interstitial, and vascular area of the kidney. So there are some glomerular diseases, which means there is a glomerular inflammation, which we call as glomerulonephritis, or any small vessel thrombosis. If there is any tubular injury, there is ischemia or toxin. Tubular injury is also caused by, what will be the toxins? These are our drugs which we used to give it for the treatment. So there is tubular injury, interstitial injury, interstitial nephritis also mainly caused by the drug. So we should always remember that. And vascular diseases like inflammation, vasculitis, and thromboembolic diseases. So now come back to the pre-renal AKI. What is the causes of pre-renal? The most common is the volume depletion, which occurs by many causes, like renal losses, which includes diuretics, and GI losses, which is caused by vomiting and diarrhea, cutaneous losses like burns, Stevens-Johnson syndrome, hemorrhage, which includes postpartum hemorrhage or any road traffic accident, sudden hemorrhage, or any intravascular injury, intraperitoneal injury like pancreatitis, and decreased cardiac output. How the decreased cardiac output is going to affect? Because if your heart is not pumping properly, it is not going to supply the kidneys properly. And if there is less renal supply, the renal perfusion will decrease and your output will decrease. So all the heart problems which will decrease blood pressure will will cause acute renal injury. That includes heart failure, pulmonary embolism, acute MI, severe valvular heart disease, abdominal compartment syndrome. What are the causes of post-renal AKI? That includes ureteric obstruction, that could be secondary to stone disease, tumor, fibrosis, ligation during pelvic surgery, because it occurs when there are certain surgeries, especially when the gynecologist is doing some surgeries. The urologist usually get a call that we have lied up the ureters. So it is sometimes the ligation during pelvic surgery. This is cause of the ureteric obstruction, which later we come to know that during the surgery, obstetric or gynecological surgery, the ureter is ligated. Or there are bladder neck obstruction, benign prostatic obstruction, benign prostatic hypertrophy. If you see a patient of like more than 50 years, always think of prostate, always get an ultrasound prostate, and you should know that is there any cause of post-renal. Cancer of the prostate, neurogenic bladder, drugs which can also cause, because they have anti-muscarinic effect, like tricyclic antidepressant, ganglionic blockers, and bladder tumor. Urethral obstruction. There are certain problems with the strictures and tumor which will lead to urethral obstruction. So come back to the renal. There are certain diseases which is caused by the glomerular. What are those diseases which you must have read? Anti-GBM disease, Goodpasture syndrome, which we sometimes use it. Anti-GBM disease is very much common in Western world, but not in our society. But we should always think, because we do see few cases of anti-GBM disease as well. ANCA, that includes vaginal granulomatosis, Churg-Strauss syndrome, microscopic polyangiitis, and immune complex mediated GN like lupus, post-infectious, post-streptococcal GN, the cryoglobulinemia, primary membranoproliferative glomerulonephritis. The tubular damage, which could be ischemic or toxic. Toxins which can cause tubular damage, we usually see heme pigments. It is very important to understand rhabdomyolysis and to thought rhabdomyolysis in any patient who has a severe muscle injury, who is bedbound, who has a road traffic accident. Then the rhabdomyolysis comes in our differential diagnosis or intravascular hemolysis. In any intravascular hemolysis, the heme pigment could lead to tubular obstruction, and that could be a toxic agent for the tubules. And there are certain crystals like tumor lysis syndrome. If there are patients of leukemia and other tumors, so this crystal pigment can cause tubular damage. And alcohol, ethylene glycol poisoning, mega dose of vitamin C, acyclovir, indinavir, methotrexate. These are all drugs which can cause tubular damage. So we should be aware of that, and we should be very careful in giving these sort of drugs like aminoglycoside, lithium, amphotericin. Where the aminoglycoside is used, it is a very good antibiotic, but we have to be very careful. Lithium is a mood stabilizing agent, but you have to be very vigilant because it has a very narrow therapeutic index, and you need to see and measure the drug levels. The next one is amphotericin B. That is antifungal. It is sometimes life-saving because the fungal infections are very lethal and it has a very high mortality. So we have to treat them. But when we are treating, we should always think that is a nephrotoxic agent. So we should hydrate patient well and see how the kidneys are going after using this drug. Pentamidine is also used in pneumocystis carinii and cisplatin. These are all chemotherapeutic and most important radio contrast agents, which we usually do it angiography or any contrast CT. That is very important for us being a physician to be aware that these agents can cause tubular damage. The interstitial damage are done by different drugs, like which we use it very commonly. That includes penicillin, cephalosporins, NSAIDs, PPI. PPI are very, very commonly used and very commonly abused drugs, which we use it every other day. And allopurinol is usually used for the gout patients or for hyperuricemic patients. Rifampicin, which you already know, that rifampicin is an anti-tuberculous drug, and we use it in ATT. So we should always be knowing that this drug can cause acute interstitial nephritis. Indinavir is an antiviral, anti-HIV drug, which is also used and causes interstitial nephritis. And sulfonamides and mesalamine. Infection. There are certain infections which could lead to interstitial nephritis and which includes pyelonephritis. Systemic diseases like Sjogren syndrome, sarcoid, lupus, lymphoma, leukemia, tubular nephritis, and uveitis. These are all the infections which could lead to interstitial nephritis. Clinical features. What are the clinical features which you would look into in a suspected patient of AKI? Number one, as we all know, that there would be a decrease or no urine output. There could be a flank pain, and a patient could be edematous because edema usually, if you just see a patient from a bedside, you can say that this patient is edematous or not. Or a patient can come to you with a hypertension or discolored urine. Asymptomatic, sometimes there is an asymptomatic elevation in the plasma creatinine abnormalities on urinalysis. What happens when a patient comes, they don't tell you each and everything. They just say we are perfectly all right, and you just do your investigation as a baseline to check whether all the baseline investigations are correct or not. So you sometimes found asymptomatic elevation of the creatinine. That is sometimes because of the drugs, and because in our society it is very common that the Hakimi and homeopathic medications are used very commonly. So always think that drugs include homeopathic and Hakimi medications. Other symptoms and signs of renal failure. What would be the signs? Patient will present with vomiting, generalized weakness, anorexia, mental status changes, seizures, and edema. And they can come with fever, especially if they have any infection underlying, or arthralgia, if they have any autoimmune diseases or pulmonary lesion. Acute renal failure diagnosis. How you are going to diagnose? It is very important that you have seen a patient, you have suspected a patient that it could be AKI or something else. So how you are going to prove? How you are going to diagnose? Just simple test. What you are going to order? You are going to order CBC. You are going to order urea creatinine electrolyte. You are going to order peripheral film. You are going to order serologies. Like, what are the serologies? You will order hepatitis B, C, HIV. These are the serologies. Urinalysis, what you are going to see in the urinalysis, what kind of cast is there? Is there any infection, pus cells, or any RBC cast? RBCs are there. Or you would like to see urinary electrolyte, especially to differentiate is it pre-renal or is it ATN. And very simple measure. Just bring your ultrasound machine and get the ultrasound kidneys of that patient. You will come to know he has got a normal sized kidney, or he has got a shrunken kidney, he has got a stone in the kidney, he has got any obstruction. So ultrasound is a very cheap and handy modality to diagnose it. And what other serologies you can send it, like ANA? We already discussed that lupus and vasculitis could cause these glomerular diseases. So we would order an ANA, ANCA, anti-double stranded DNA, anti-GBM antibodies, serum cryoglobulin levels, CK creatinine kinase or CPK levels for rhabdomyolysis, and urinary myoglobulin levels. Urinalysis, unremarkable sometimes in pre and post-renal causes, but it differentiates usually in ATN versus AIN versus AGN. So how it would differentiate? In ATN, you would see a muddy brown cast in ATN. And what you would see in acute interstitial nephritis, you would see a WBC cast, which you could see it by a special stain called Hansen and Wright stain. What you would see in acute glomerulonephritis? In acute glomerulonephritis, you would see in a urine that the patient has an RBC, and there is a RBC cast. What is a cast? Cast is the broken RBC. If you see it under the microscope, it is a broken sort of RBCs. That shows it is coming from your kidneys, not from your bladder. So, acute renal failure diagnosis, how you are going to diagnose? There are certain calculations and things which you don't need to understand actually. You just need to understand what is a FeNA, fractional excretion of sodium. That is less than 1 in pre-renal, may be low in selected intrinsic causes like contrast nephropathy, acute GN, and myoglobin. And FeNA would be high in intrinsic cause of ARF. So it would just differentiate between pre-renal and intrinsic cause of ARF. Acute renal failure diagnosis. So serum creatinine, more reliable marker of GFR, because nowadays the laboratories have started doing eGFR. Whenever you order creatinine, they will give you an eGFR. Achha. They sometimes it is falsely elevated due to the drug intake, and blood urea nitrogen usually follows serum creatinine increase, and but sometimes, usually it follows whenever there is a rise in creatinine, but sometimes you would see there is a high urea or burn and as compared to your creatinine. And there are certain causes or states which you can always remember, that if a patient is taking high level of steroids, or he's in a high catabolic state or hypovolemia, his urea would be more high or as compared to creatinine. That would suggest that this is more likely a pre-renal cause, because we have a certain ratios like we 20:1. If it is more than 20:1, we would call it a pre-renal cause. So how you would differentiate in acute and chronic renal failure? Acute, the history would be short, like days to weeks. Chronic, months to year. It is very important to see CBC. What you would see in CBC? CBC will show low hemoglobin level in CKD patient. Why? Because there's a hormone released by the kidneys would be suppressed during CKD, not AKI. So you would be seeing a normal hemoglobin level in AKI, and you would see a suppressed hemoglobin level in CKD patient. What would be the renal size? If a chronic kidney disease of intrinsic origin like glomerular diseases, the kidney size would be reduced, and in the AKI, the renal size would be normal. So, but there are two exceptions which are very common. You should always remember diabetes and hypertension. You would see a normal kidney size. You will come across many patients who will come to you and say, डॉक्टर साहब हमारी तो किडनी बिल्कुल नॉर्मल है, फिर एकदम से हम क्या हो गया, हमारा क्रेटिनिन क्यों बढ़ गया, why it has gone so high. So you should always remember a patient who is diabetic, hypertensive would have a normal kidney size, and a patient of HIV would also have a normal kidney size, not reduced kidney size. The next is renal osteodystrophy. You all must be knowing that kidney has a role in maintaining bone mineral metabolism. That includes your calcium, phosphorus, and parathyroid hormone. So this is this is normal in AKI, and this is present in chronic kidney disease. Peripheral neuropathy, that would be absent in acute kidney disease, present in chronic kidney disease. Serum creatinine acutely reversible होगा and उसमें chronically elevated होगा. So there are laboratory tests useful in diagnosis of ARF. As we already discussed, that what are the things which will favor pre-renal and which would favor acute intrinsic causes like ATN. BUN ratio more than 20:1 favors pre-renal. Rise in serum creatinine and urinalysis में आपको क्या मिलेगा pre-renal में और ATN में, और urine osmolarity usually high होगी pre-renal में, ATN में low होगी. Urinary sodium usually low होगा pre-renal में और high होगा ATN में. FeNA pre-renal में low होगा और post-renal में high होगा. ठीक है, acute renal failure में causes में वही hypovolemia, renal में acute, this we already discussed. So just ATN, most common of intrinsic cause of ARF, often multifactorial. What is the cause of ischemic ATN? That could be hypotension, sepsis, prolonged renal state. And nephrotoxic ATN, like contrast, antibiotics, and heme proteins, which we already discussed. Acute tubular necrosis में FeNA more than 2, sediment with post-granular cast. Treatment क्या होगा? Maintenance of euvolemia with judicious use of diuretics, IVF, intravenous fluid as necessary, avoidance of hypotension, avoidance of nephrotoxic drugs. What are the nephrotoxic drugs? You all already must be knowing NSAIDs and ACE inhibitor, ARBs when possible. Dialysis if necessary. Usually ATN is reversible, 80% will recover if initial insult can be reversed. Contrast nephropathy, that is very important to understand, because nowadays medicine has gone a way forward and everything is, very dynamic, that you already have to prove evidence-based medicine, and you are going for invasive testing all the time. So you are going to do contrast every other day. So you will come across a patient who usually comes to you from a cardiologist or gastroenterologist that they have advised angiography or TACE, but when they check the creatinine, it is 1.7 or 1.9. So what to do now? Should we go for the angiography, or should we wait till the creatinine will go down? So it is important to understand contrast nephropathy. So it occurs in 12 to 24 hours post exposure, peaks in 3 to 5 days. It is a non-oliguric. FeNA is always low. No treatment is there. Only prevention is there. And you have to give good IV hydration to prevent contrast nephropathy. And there are certain studies which have showed there are some benefit in using N-acetylcysteine, and that you can use it with mucolator starches, and because ideally it should be used by IV N-acetylcysteine, but it is very rarely available here in Pakistan. But you have to analyze the risk factors, because not everybody will go in contrast nephropathy. Those who are diabetic, those who have ischemic heart disease, and those who have congestive heart failure or hypovolemic are at increased risk of contrast nephropathy. So what are the recommendations for prevention? Identify karna hai high risk patient, use low risk contrast in high risk population. We usually write down to use the lowest possible amount of dye, because the more you use the amount of dye, the more the chances you will get the contrast nephropathy. Volume expand karna hai, you have to do it with isotonic crystalloid, and it is not actually been proven that role of N-acetylcysteine, but still few of the studies have shown benefits, so still people are using it. Role of statin भी plus minus है. जो अगर if the patient is on any nephrotoxic agent, just stop it and no need to discontinue. Just stop it, and in chronic, if the patient is on chronic diuretics, you have to stop it. Another very important disease which you should always be remembering is rhabdomyolysis, which would cause acute AKI. So rhabdomyolysis, what happened in rhabdomyolysis? It's what kind of injury it will cause? It will cause a tubular damage. Okay, the heme pigment will got stuck in the tubules and cause acute tubular damage. How we are going to diagnose? We are going to diagnose by doing CPK level, which would be more than 2000. Urine dipstick में Urine dipstick would be positive for blood without RBCs on microscopy, and pigmented granular cast would be present. And it usually occurs rhabdomyolysis after crush injury, seizures, burns, limb ischemia, occasionally after IABP or cardiopulmonary bypass. These are the surgeries which you use it in cardiology. And treatment is usually supportive with intravenous fluid. Acute glomerulonephritis, how we are going to diagnose by history, hematuria, and we see RBC cast, proteinuria, usually non-nephrotic, low serum complement in post-infectious GN, and RPGN associated with anti-GBM or ANCA. Usually will need to perform renal biopsy to diagnose acute GN. Erythroembolic ARF associated with emboli or fragments of atherosclerotic plaque from aorta and other large arteries. This erythroembolic ARF usually occurs when a patient has gone through, the angioplasty or any interventions in the vessel. Then there are chances of, getting the small thromboemboli or fat emboli to go in other vessels. So it is diagnosed by the history, physical examination, evidence of embolic phenomena like CV ischemic digits, blue toe syndrome, and they have a low serum C3, C4 level, peripheral eosinophiluria, and rarely WBC cause. Commonly occur after intravascular procedure or cannulation, cardiac cath, cabbage, A repair. Acute interstitial nephritis usually drug induced होता है, methicillin, rifampicin, NSAID. Develops 3 to 7 days after exposure. Fever, rash, eosinophilias are common, and these patients have WBC casts which are positive on Hensel and Wright stain, often resolved spontaneously, and sometimes using of steroids may be beneficial in acute interstitial nephritis, especially when the patient have rise in creatinine. What is the treatment of AKI? Number one would be optimization of hemodynamic and volume status, like good IV hydration, avoidance of further renal insults, like you should not give any nephrotoxic or other agents would further compromise your renal status. Optimization of the nutrition. Nutrition is always important in any sort of disease. And institution of renal replacement therapy like dialysis, because in AKI sometimes you need to do early dialysis in order to prevent life-threatening events. So it is important to take decision early. Okay, and indication of renal replacement therapy. What are the things which you would see in a patient to decide whether to go for a dialysis or not? Number one, symptoms of uremia, like patient will present with nausea, vomiting, severe edema and fluid overload. Other is uremic pericarditis. The third one is refractory volume overload. Fourth one is refractory hyperkalemia. And the last one is refractory metabolic acidosis. So this is the combination of all the things that you would see. Any of them can lead to a physician to go for a hemodialysis, like a hyperkalemia, like potassium of 7 would put patient in a situation that we would advise urgent hemodialysis. A patient with severe metabolic acidosis, like a pH of 6.9 and a bicarb of 4, would recommend that we would go for hemodialysis. And how the KDIGO acute kidney injury clinical practice guideline would say that initiate renal replacement therapy emergently when life-threatening changes in fluid, electrolyte, and acid-base balance excess. and consider the broad clinical context, the presence of conditions that can be modified with renal replacement therapy and trends of laboratory tests rather than single BUN. Actually, the trends are important. For example, I saw a patient in the morning that has a creatinine of 1.5 or 1.6 in the morning. I would order that I want to repeat serum creatinine and burn in the evening to see how the things are going and to see how much urine he has started pouring. So the trends are important. In the evening, if I, for example, if I see a patient from 1.6 and it creep up or jump up to 2.9, I would rather go for dialysis urgently. But in a similar sort of patient, if I saw a patient that was 1.5 in the morning and if in the evening it's still 1.5, so I would like to wait and see how the things are going. I will not initiate dialysis because the patient is static. And we have another thing we would like to share with you, that furosemide stress test is very popular among nephrologists in our society, in our community, because we would like to use all conservative things before going for a dialysis, because dialysis is not a first line of acceptance by most of the patients or by their families. So what we will do is we will administer furosemide and loop, that is loop diuretic, 1 mg per kg, and one to two, actually we usually give 1 to 2 mg per kg of patient's weight, like 100 mg. If a patient comes to you with a weight of 70, so we would like to give 100 mg furosemide stress test. But if a urine output is not adequate, then the next step would be hemodialysis. What are the modalities of renal replacement therapy? We have several modalities like intermittent hemodialysis. We can do continuous CRRT, that includes continuous hemofiltration, continuous hemodialysis, and continuous hemodiafiltration, and prolonged intermittent renal replacement therapy by doing SLED method. There are certain methods by which we can do dialysis, and there is another method like peritoneal dialysis. So in the summary, there are insufficient data to determine optimal timing of renal. I would summarize like that it is very difficult that whether to go early or late. You have to judge it. The clinical judgment is very important for a physician, because you have to judge it when to initiate dialysis. Clinical trials to evaluate timing needs to include patients who meet criteria for early initiation but recover or die without receiving renal replacement therapy. Current evidence suggests that a strategy of delayed renal replacement therapy may not be inferior to early initiation of renal replacement therapy and may reduce the number of patients requiring renal replacement therapy. Although severity of fluid overload is strongly associated with adverse outcomes, there are insufficient data to conclude that initiation of therapy based on severity of fluid overload decrease mortality. Studies comparing modalities of renal replacement in AKI have not demonstrated superiority of any individual modality. So, selection of modality should be guided by expertise and resources available at the individual institution. For example, if we at Dow have only intermittent hemodialysis, so we should continue to use intermediate hemodialysis. There is no superiority in using CRT. CRT has an added benefit, especially in those patients who have very low blood pressure, but it is a very expensive modality. It will cost patient a lot. Thanks. So I would like to take any questions if you have, so kindly ask any questions. I have got one question from Hamara Mustaqbil. No. Is there any possibility of increased urine output since the filtration system is destroyed? Yes, there is a chance of getting reversal of that injury because AKI is reversible. That is what I try to convey you, that there are certain stages when the AKI is reversible by doing proper vigilant, you know, vigilance to the patient, good IV hydration, avoidance of nephrotoxic agents would recover patient well. Any further questions, please? Okay, I think no questions. So I leave here. And if you have any further questions, you can write down to me on my email address, and I would love to answer any questions. Thank you very much.